also have a clinical consultation line. Note the toll-free numbers on this slide. You can find us on Facebook and Twitter, and if you'd like to tweet about interesting points that you learned today, please use the hashtag STDRX. Now let's review the interactive features of the webinar format. In the bottom right-hand corner of your screen, you'll find the question and answer box. At any time during the webinar, you can type in a question here. Your questions will not be visible to the entire group of participants, but we'll be collecting them, and we will address as many as we can during the Q&A portion at the end of the webinar. Above the Q&A box on the right side of your screen is the chat box. You can type comments or questions in the chat box that you would like to share with the other webinar participants. We have over 200 participants from across the country signed up today. And finally, there will be a couple of times during Dr. Yang's talk that we'll ask you to respond with an answer or best guess, and an audience poll box will appear, and you can mark your answer by moving your cursor to your answer and clicking. We're going to test the audience function poll for just a moment now. We'd like to know how many people are listening today at the location where you are. If someone at each site can respond to the poll by inserting the number of people who are watching at your location, that would be great. This will help us determine a more accurate count of how many people are participating today. So let's broadcast our results and end the poll. Okay, moving on now to continuing education credits. This webinar is approved for 1 hour of continuing medical education credit or 1.2 hours of nursing education credits. If you would like continuing education credit, here's what you will need to do. After the webinar, complete the post-course evaluation, which is a SurveyMonkey evaluation. The SurveyMonkey link has been sent to your email address, and the link will also be posted at the close of this webinar. To receive continuing education credits, you must complete the post-course evaluation. After you complete the short evaluation, please allow 1 week for processing. You will be able to print your certificate by logging onto our website and signing in under My Trainings. If you would like continuing education credits and haven't registered yet, you will need to register first, and then complete the evaluation so as to receive your CME or CEs. And even if you do not need continuing education credit, we'd love to have you complete the evaluation. Information from the evaluation is used in planning future training events. Also, after the webinar, we will post the slides and email a link to all registered participants. Regarding conflicts of interest, Dr. Yang has no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Now I'd like to introduce our speaker for today. Dr. Catherine Yang is a clinical professor of pharmacy in the School of Pharmacy and a pharmacist specialist in infectious diseases at the University of California, San Francisco. She received her Master's of Public Health degree from the University of California, Berkeley in 2001. Her specialties include infectious diseases and epidemiology, particularly the management of multi-drug resistant infections. She has had an extensive and distinguished teaching career since 1999. She is a reviewer for several scholarly and professional journals and has co-authored several journal articles, as well as 2 books on pharmacology and antibiotic resistance in the ICU. We are so pleased to have Dr. Yang join us today to share her expertise, speaking on common antibiotic conundrums and clinical pearls. Dr. Yang, we will now turn the webinar over to you.
Thank you so much, Sharon. It's such a pleasure to be here today. Today we're going to talk about specific issues in the management of STDs, specifically how do we manage potential drug hypersensitivity reactions. And I say potential because we often get a lot of patients coming in that say, I have a drug allergy, and it's really up to us to be the detectives to figure out whether or not that is actually true. There's also been a lot of press recently on the risk of arrhythmias and sudden cardiac death associated with the Macrolides, Azithromycin, and fluoroquinolones. So I thought we should go over the data and really see what the risk is. Then we'll finish up with some information on drug-drug interactions. We often do get a lot of patients that come in who are on a whole slew of medications or herbals. And again, it's up to us as the detectives to figure out whether or not those interactions are clinically significant. And lastly, we'll leave some time at the end for you to chat in some questions that you might have from your patients, or if you've ever had any management issues that you want to discuss. So first of all, I thought I would start with the penicillins. So as you know, penicillin is the mainstay for treatment of syphilis, and it's an inhibitor of bacterial cell wall synthesis. Luckily for us, pen-resistant syphilis has never been isolated, which is why we can still use penicillin today, even after all of these years. I wish that was true for any other bacteria. IV Pen-G is always the preferred drug of choice for all stages of syphilis, IV or IM. We never give it PO, and depending on the stage of disease, as you know, determines the dose that we give. So luckily for us, the minimum serum concentrations that we need to eradicate syphilis in the body is very, very low, 0.018 microgram per mil, which is why we have the treatments that we have today. As you know, there are multiple formulations. There is Pen-G benzathine, which is the one that we use in the clinic. That's an IM formulation. There is a Pen-G procaine, which we should not be using because that's one that's dosed every 24 hours. And it's often given with probenecid to inhibit secretion and to keep the concentrations in the blood higher. And lastly, we have Pen-G, which is the IV form, and that's used for neurosyphilis and syphilis in pregnancy, as well as tertiary syphilis. And there are multiple formulations available for that. There is an IV formulation that is a sodium salt as well as a potassium salt, and we will sometimes change those depending on whether or not the patient is fluid overloaded or has electrolyte imbalances, or if they have renal dysfunction where they can't tolerate a lot of electrolytes, we'll often change the formulation that we use. So here is just a quick graph of the pharmacokinetics of each of the different preparations. And when I mentioned that syphilis has a very low MIC and require low concentrations, you can see that we need concentrations down here, which is why the benzathine version works so well, because we can give a single shot and you get these low levels for multiple days, so up to 5-7 days that were over the MIC of the organism. That's in contrast to procaine, which gives you sort of this middle increase and then goes down after about 12 hours or so, which is why procaine penicillin needs to be dosed once a day. And lastly, we have IV penicillin, which gives you these very, very high peak levels. And this formulation is used for neurosyphilis because you can get very, very high levels in CSF. And it has a very, very short half-life, which means for a patient being treated for neurosyphilis, you often have to give the drug every 4 to 6 hours. But you get these very, very high peak concentrations specifically so you can get into CSF. You would never treat a patient with neurosyphilis with either the benzathine or the procaine because you wouldn't get levels high enough that would cross the blood-brain barrier. Okay, so moving on to adverse effects, the most common things we see with penicillin are diarrhea and now C. difficile. And in the past we used to think of C. diff as an infection you get in immunocompromised patients or an infection you get in the hospital if you've been given a lot of antibiotics. That is no longer really the case. So now we see C. diff in the community all the time. even with kids that are given simple amoxicillin for an ear infection or Augmentin or doxycycline. And actually, a few months ago, one of my friends texted me to tell me that her son actually got C. diff for getting a little bit of Keflex for a skin infection. So that's how prevalent it is in the community now. So now when you have a patient who calls you back after getting antibiotics and says, I have diarrhea, it's really up to you now to figure out, is this a diarrhea associated with just normal penicillin or levofloxacin dosing, or is this something more severe, such as C. diff diarrhea? And things you can ask them include questions like, how often do you have the diarrhea? How bad is it? How many days have you had it, etc. As you know, you can get a Jarisch-Herxheimer reaction from getting penicillin for syphilis, and this is an acute febrile reaction that can give you headaches, myalgia, chills, and fever. It's usually self-limiting. It happens in the first few hours of the dose and usually goes away by 24 hours or so. It's thought to be due to release of the toxins from rapid lysis of the organisms, which is why you see it most commonly in early syphilis and secondary syphilis. You also get a massive release of cytokines, which is probably the other reason you get this sort of flu-like syndrome. There is no real proven methods to prevent this reaction, although some people have tried giving low-dose corticosteroids as a way to prevent this. And that might be something you think about if you have a patient who has localized syphilis lesions, such as in the eye or on the skin, because with the Jarisch-Herxheimer reaction, you can often get a localized flare. In pregnancy, as you know, you can induce early labor or fetal distress. And usually all you need to do to treat is to give a little bit of Tylenol or some ibuprofen. And lastly, with the procaine formulation of penicillin, you can get a procaine reaction. Now, this is actually a really interesting reaction because patients get this feeling of impending doom or severe anxiety with the shot, even though they have no other physiological symptoms where their blood pressure is normal, their heart rate is normal, and everything else is essentially normal. It's just that they have this feeling that of intense anxiety. And this is something that people have thought is also more likely to occur in patients who have underlying psychiatric disorder. So moving on to hypersensitivity reactions. So many of you may have remembered that there was breaking news in April of this year that Miley Cyrus was hospitalized for a severe allergic reaction. And this made big news. It was, all over the internet. It was on the radio. And she was tweeting pictures about herself, saying that she was hospitalized and she had to cancel tour dates because of this. So I thought it was sort of interesting. So I did a little digging into the history behind this. And it turns out she was given an oral first-generation cephalosporin for a sinus infection. And then she became hospitalized. So the thing about this picture that I love is, besides the fact that it's got TMZ on it, is that she shows her face, and looking at her face, although she's hiding her mouth, that's the one thing is with this little octopus, she's hiding her mouth, but otherwise her skin is clear and her eyes are clear. So I was looking at these pictures, looking for any type of objective symptoms of what type of reaction this was. So this leads to our first polling question. Does my patient have a penicillin allergy? So you prescribe a 10-day course of Augmentin, which is amoxicillin clavulanic acid, to a 6-year-old female with group A strep pharyngitis. She returns to your clinic 5 days later into therapy with a full body rash. So this is what it looks like. This is actually my neighbor. Her mother texted me this picture of her because she was given Augmentin for what she thought was a strep throat. And lo and behold, a few days later, she broke out into this full body rash. And what you can see from this picture is it's a very symmetrical, it looks like almost like a lawn of rash. It's small, there are little red spots, and you can see it covers her back, it covers her face, it covers her chest. The other thing about this picture that I find interesting is she's completely happy in the process. You know, she doesn't have any fever, she feels fine, and when you ask her if it itches, the mother said, well, if you don't ask her, she doesn't scratch, but if you ask her, she'll say it's itchy. But if you watch her any other time, she's not scratching, so it's a non-itchy rash. So what do you do? And this is where you turn on your polling questions. Do you A, DC the augmentin, start Pen-VK, B, DC augmentin, start azithromycin, C, DC and then start levofloxacin, D, desensitize the patient, or do nothing and continue therapy with augmentin? Okay, so I'm trying to look at the votes now. I think I click on this. Whoops, maybe not. It looks like most people would DC augmentin start azithromycin. The second most common was to continue therapy with augmentin. And actually that is the right answer. The right answer is actually you would do nothing, continue therapy. And why is that? Oops. I don't know how to close that. What happened there? Okay. So the reason you don't do anything is because this is a macular-papular rash associated with augmentin. But what do you ask a patient when you are suspecting that they have a antibiotic allergy? What was the reaction? Did they have difficulty breathing? Did they have a rash? And when they say rash, you really have to ask them, what did the rash look like? Because a macular-papular rash versus an urticaria to some patients is still a rash. Did it blister, etc.? You also want to know who told you you had the reaction. So did they remember the reaction, or they were told by a family member, it's usually a parent, that you had a reaction when you were a child? And that was the case with myself. So I was told I had a penicillin allergy. I don't actually remember it, but that's what I was told. I've since challenged myself with penicillin, and I've done fine. I wouldn't recommend that. But sometimes when you get secondhand information, it's not always the best. How long after you took the drug did the reaction start? So that helps you decide if it's an immediate hypersensitivity reaction, such as anaphylaxis, versus you had this macular-papular rash associated with augmentin. What other medications were you taking? This is important to ask just so you can figure out, was the allergy truly due to the antibiotic, or was it something else? Why and when were they prescribed? So what were you taking it for? What happened when the drug was discontinued? So some reactions will go away as soon as you discontinue the drug. And something like a side effect is something where that would occur, nausea, vomiting, etc. Sometimes drug allergies, when they occur, can take a while before they actually subside. Even after you discontinue the drug, you have to allow the process to run its course. So they may actually take a while. What other antibiotics have you taken? So this is important for two reasons. One is you want to know what other antibiotics you can prescribe them, so you can find out if they're allergic to pen, can they take a cephalosporin. But the other reason is because sometimes they'll say, oh my God, I'm absolutely allergic to penicillin, I cannot take any penicillins. And then you find out they've taken amoxicillin and they don't know that's within the same class. And this is always a good opportunity when you're talking to the patient to get some more information about their cultural beliefs about antibiotics, which is always important in order for you to increase adherence. So many cultures have very specific feelings about antibiotics. For instance, I know in some Asian countries, if you go to the physician and they don't give you an antibiotic, they consider that doctor to be not very valid. So these are also questions that you should ask them beforehand so you have a good idea of how they feel about taking antibiotics and what they've taken before. So diagnosis of drug allergies is always a very confusing picture. There is no test, there's no physical exam that is usually very helpful, and you have to go by what the patient says. So asking good questions about any infections they've had in the past and why they've taken it is very important. There are very few diagnostic tests, especially for some of the more obscure infections, and it's oftentimes a diagnosis of exclusion, meaning that you've sort of ruled out everything else and the only thing you're left with is a drug allergy. And I get this all the time. So we have a patient in the hospital who has a fever, and every test that we've done for doing every culture comes back negative. And the only thing that we can decide is that the patient has a drug fever. And then the only thing we can do at that point is to discontinue the drug and see what happens. So in terms of penicillin allergies, most patients who report a penicillin allergy are not truly allergic. And what I mean by that is they have a negative skin test. So the true incidence is about 10%, and that includes all comers. So that includes the rash, that includes anaphylaxis, that includes your blood dyscrasias such as neutropenia or anemia. True anaphylaxis is very rare, about 1 to 5 patients per 10,000. I feel like it's more common than that because I see them in the hospital all the time. But in general, in the community, it's quite low. So immediate type reactions are the ones that we always worry about. These are the type 1 IgE-mediated reactions where you get the anaphylaxis. And the onset is usually pretty quick, within an hour, but you can also get accelerated reactions that can occur up to 72 hours after the dose. These are the only type of reactions that you can actually do a skin test for. And as I said before, that the incidence is quite low, and you also know what the clinical features are. So you get erythema, you get itching, you can get laryngeal edema, you can get bronchoconstriction or wheezing, you get hives, and you can get hypotension and cardiovascular collapse in the most severe situations. In this case, in these patients, you never re-challenge them, and you avoid all beta-lactams in general. So this is urticaria. So these are hives. And in contrast to Kaylee's rash a few slides back, this is a very flat-looking rash. And it comes in big plaques. It moves around. So you may have hives in one location at one time, and then they'll pop up somewhere else, and then they'll disappear, and they'll move somewhere else. You can see that there's a little bit of blanching underneath the rash. So it's usually only the rash part is raised, and it's very flat and pink, and underneath, if you pressed on it, it would blanch a little bit. This is very different from the macular papular rash that we saw before. And this is angioedema. So this is actually quite uncommon, but what happens is you get a swelling of the tongue that can be so severe that the tongue no longer fits in the mouth, and they can definitely have compromised breathing. And in most cases, when patients are hospitalized, they're in the ICU because you either have to intubate them or you have to do something else to keep their airway open. This is a life-threatening event. So back to Miley Cyrus. So did she have a type 1 mediated reaction? That's the big question, because outside of that, I can't think of many other things that would have hospitalized her with an allergic reaction. So luckily for us, we have a lot of baseline images of her tongue, so we can compare to see if she had angioedema, and this is what her tongue looks like, you know, at baseline. And this is the picture of herself that she tweeted from the hospital room. I can't say for sure that she didn't, but what strikes me is she was still able to fit her face into a pediatric mask, which makes me think that she didn't actually have angioedema. And her face is still clear. So the likelihood that this was an IgE type reaction is lower in my opinion. However, she must have had some kind of compromised respiratory something in order to need a mask to breathe. So I think the jury is out. I just thought it was a cute example and a good way to sort of go through the diagnostic criteria. So this leads to our second question. My patient previously had a rash of PenVK. Can I prescribe ceftriaxone for gonorrhea? A, yes, the two drugs are different. No, they are both beta-lactams. Or C, it depends. So this is where we do our polling. And good, it looks like most people say it depends, and that is correct. Although if you said yes, the two drugs are different, you wouldn't be entirely wrong. It would really, again, depend on what the reaction was. Okay. So moving on to the next slide. So what is the cross-reactivity of the beta-lactams? So this here is the structure of a penicillin. So this is the basic structure of penicillin, amoxicillin, nafcillin, etc. The cross-reactivity to a cephalosporin, such as ceftriaxone, is on the order about 1 to 5%. The cross-reactivity to a carbapenem, which we use in the IV, is about the same, 5%. And to a monobactam, which is azithromycin, is basically 0. So this is the drug that we give in the hospital all the time to patients who have true type 1 allergic reactions to penicillin. Now the problem with all of this information on cross-reactivity is we don't know what it is going the other way. So if you have a patient who says, I'm allergic to ceftriaxone, you really have no idea what that means going back to a penicillin. Or if you have a patient who has a carbapenem allergy, what that means going back. Either way. So we don't know what it means going between classes. The only information we do know is going from a penicillin to a cephalosporin. So now we have late reactions. And late reactions are ones that occur 72 hours after exposure. These are not IgE mediated, so cannot be skin tested for. So we have the type 2 reactions, which are immune complexes with your either red cells or your platelets, and they're IgG-mediated reactions that can cause hemolytic anemia or thrombocytopenia. They're associated with high doses, so this is something I wouldn't expect you to see unless you were treating someone for neurosyphilis, and it's reversible once the drug is taken away. You also have type 4 reactions, which are serum sickness, and this is fairly rare as well. This is more of a generalized malaise feeling, a flu-like symptom. And then on the way end of the scale, you have Stevens-Johnson syndrome, which are exfoliative rashes, where you can look like a burn patient. And these can occur up to 3 weeks after drug administration, and they're very, very rare, but they can be fatal. So this is a picture of Stevens-Johnson syndrome. You basically get a blistering rash on any part of your body that has epithelial surfaces. So mainly that's your skin, but can happen anywhere else, such as your eye, so on your cornea, or in your GI tract. So if people are complaining of severe abdominal pain or esophagitis, that sometimes that has occurred. I've only seen it a few times, but we have seen Stevens-Johnson in the esophagus. And then we have these idiopathic reactions, which are known as ampicillin rashes. So this is the rash that Kaylee had. It occurs in up to 9% of people taking ampicillin, and we don't exactly know the mechanism behind it. It gives you a very symmetrical confluent rash, and it's always been associated with concomitant viral infections, which is why kids get a lot of rashes, especially when they go to the doctor. They likely have some type of upper respiratory infection. The mother pressures the physician for some kind of antibiotic. They give ampicillin or amoxicillin, and boom, they have a rash. It resolves on its own, and you can re-challenge with no issue. The main thing to remember about this is you don't classify it as a penicillin allergy. So again, it lasts about 3 days, can be as long as a week. It does not respond to diphenhydramine, and the reason for that is because it is not IgE mediated and there's no histamine release. Don't stop the antibiotic, you just have to treat through it and do good education to the patient. And you can take amoxicillin next time, likely without rash. So this is just a couple slides on penicillin desensitization. I'm going to leave these in here for you to look at, since this is something that's pretty specialized. If you do have a patient where you do need to go to the hospital and do penicillin desensitization for, say, neurosyphilis or for pregnancy, this is how you would do it. So I'll just leave that in here for you to look at. And this is an example of a desensitization protocol. There are many out there, and they're all equally good. The main thing is you just start with very small doses and you work yourself up to the full dose of the antibiotic. And the other thing to remember is you cannot stop a dose once you're desensitized. So if you stop a dose or you miss a dose, then you basically have to start over. And here's the summary tables of the reactions we've talked about so far. So I have here on the left-hand column whether or not the reaction is predicted with skin testing. And of course, the only ones that are the type 1 anaphylaxis and the accelerated reactions. Nothing else is. And these two are the only two types of reactions that you can test with skin testing that you should not give a penicillin to. Okay? If you have any other type of reaction, they cannot be skin tested for, and you can likely give them again, except for Stevens-Johnson, because Stevens-Johnson can be a life-threatening event and is an absolute no for any other beta-lactam, including cephalosporins. And lastly, I have drug intolerance here because it's always important to educate the patient that their drug intolerance is not an allergy so that they can get a cephalosporin. Okay, so moving on to our next session, we're going to talk about cardiac arrhythmias and the risk associated with azithromycin and fluoroquinolones. I think actually this is a very interesting topic because there's been so much information that's been coming out in the past year or so about this particular adverse event. So cardiac arrhythmias can include things like QT prolongation, torsades in the very extreme situations, and cardiac deaths. And these have been known with fluoroquinolones and azithromycin as classes. And what I find interesting is the focus of cardiac arrhythmias and antibiotics has really been focused on azithromycin. And the reason being is because there are over 40 million people who get azithromycin in the U.S. per year. And if you think about that, that's like 1/8 of the U.S. population. So it's the #1 drug prescribed in the U.S. Fluoroquinolones are not that far behind because they are often given for UTI and pneumonia, but the focus of late has been on azithromycin. Other macrolides are also known to cause QT prolongation, especially erythromycin, but that is likely due to its Cytochrome P450 inhibiting effects. So risk factors for cardiac arrhythmias would be the same risk factors you would think of in any person. So electrolyte imbalances, known underlying cardiovascular disease, patients receiving known drugs to cause arrhythmias, and of course the elderly. So in 2012, there was a paper published in the New England Journal of Medicine. This is what got everyone sort of up in arms. So they looked at azithromycin and the risk of death, risk of cardiac death. And what they did was look at about 348,000 Tennessee Medicaid patients between 1992 and 2006 who took azithromycin. And they basically looked at the Z-Pack dose compared to patients who took either amoxicillin or no antibiotic. And although I don't put it in the slide, was a patient that was on average about 50 years old, and interestingly mainly women. So 78% of this population were women. And it was the antibiotic was taken mostly for upper respiratory infections, although some did also take for there were some patients who took Levo for UTI or GU infections. And looking at this slide, so on the left here, you're looking at the risk of cardiovascular death, and then on the right here, you're looking at death from any cause. And because azithromycin is taken as a Z-Pak, they looked at the hazard ratio at 5 days, because that's how long you would take a Z-Pak, versus 10 days of amoxicillin, because that would be the standard course for amoxicillin. So in this slide, looking at azithromycin versus no drug, you can see that after just 5 days of therapy with azithromycin, the hazard ratio of cardiovascular death was 2.88. But after 5 days, this risk went away. So the hazard ratio dropped back down to normal after the 5 days. And that was also seen with death from any causes. And so you can see here that the number of deaths associated with azithromycin after 5 days is on the order of about 80 cumulative deaths per 1 million. It's not huge, but definitely more so than no antibiotic, and you see that here as well. So when they compared to amoxicillin, they pretty much got the same thing. So you see the most increase in death within the first 5 days, and that went away after 5 days, and here as well. So even with just a 5-day course of azithromycin, there was an increased risk in cardiovascular and all-cause death. So this got the FDA up in arms, and they started investigating this. Subsequently, there was another paper published in the Annals of Family Medicine that looked at azithromycin as well as levofloxacin for increased risk of cardiac death and arrhythmias. So in this study, they looked at 1.77 million U.S. veterans who received amoxicillin, azithromycin, or Levo between 1999 and 2012. So again, they used the Z-Pak compared to Levo 10 days or amoxicillin 10 days, typical doses for your upper respiratory infection. And in this population of patients, they were again about 50 years or so, but in this population, interestingly, because they were U.S. veterans, they were mainly men. And what they found in this study was, again, there was an elevated risk of serious cardiac arrhythmias when the patients took Levo or azithromycin compared to amoxicillin. And you can see here the hazard ratio for azithromycin was on the order of about 2.33 for the first 5 days, and it dropped a little bit. So after 5 days, that risk went away. For levofloxacin, it was still fairly high, and actually what strikes me about this study is the highest risk of death in this study came from Levo. And if you look at cumulative death due to all causes, again, levofloxacin was the highest one, and as well, and azithromycin also did have an elevated increase in death. Interestingly, everyone seems to focus on azithromycin, but in this study, levofloxacin was the higher one. So then last study, and I think I lost the reference, this came out, I think, last year, the lack of association between azithromycin and death from cardiovascular causes, looking at 1 gram, so the STD dose of azithromycin for gonorrhea and chlamydia. And this was studied in a population of about 162,000 patients, young patients, mean age of 24, who got azithromycin between 1993 and 2010. So in this population, they had low baseline cardiovascular risk. And what they found was the risk of death due to azithromycin with a single one-time dose was basically nothing. So of course, this was a smaller study, and it was just a letter to the editor. Oh, there's the reference, 2014. But this was very reassuring to people who were giving the azithromycin for STD. So what do all these studies mean? So I have apples and oranges here because, of course, the 3 studies are actually very different. So it is definitely true there's an increased risk of prolonged QT as well as rare torsades and even death, even when given in short course therapy, so less than or equal to 5 days. However, the source population is clearly very important, so a younger population of patients clearly is going to be at less risk than an older population, which is something, of course, we would assume to be true. And is azithromycin 1 or 2 grams PO for, say, Neisseria the same as 5 days for a Z-Pak? And I think the jury is still out. I would say that for your patients who are younger, a 1 or 2 gram dose of azithromycin is not a big deal. Whether or not it gives you an increased risk in an older population, I think likelihood of increased toxicity is also still low. However, I would always try to take a good cardiac history. If the patient already has some type of underlying cardiac disease, is on antiarrhythmics, amiodarone, etc., that might give me pause to think about it a little bit. And when I try to look into the mechanism of this, looking at 2 grams of azithromycin and what the blood levels are relative to, say, a Z-Pak, they're probably very comparable. Interestingly, there's no data on the actual PK of 2 grams, even when I called the company. But I assume it would be very similar to a 500 times 1 and then 250 milligrams for 4 days that you would get in a Z-Pak. Okay, so the last topic we're going to talk about is management of drug-drug interactions. So first of all, I thought we would talk about interactions that are simple and easily managed. So the ones that come to mind are fluoroquinolones and tetracyclines. As many of you probably know, these 2 oral agents bind multivalent cations. So if you have a patient who is taking, say, levofloxacin or doxycycline, you need to actually do quite a bit of counseling about needing to separate that dose from anything that has magnesium, aluminum, calcium, or zinc, or I forgot to put on this, but iron as well, and there's my picture of the iron. So what happens is they bind the drug in the GI tract, and my example here is if you give ciprofloxacin with Tums, you can actually lead to a 60% decrease in drug levels, and that can definitely affect your efficacy rate for the drug. So what we always do is put an auxiliary label on our drugs and tell the patients that you have to take them 2 hours before or 6 hours after cation containing products. And that includes things like dairy products, your ice cream, your yogurt. So again, another opportunity for culturally sensitive counseling is always to ask the patient about their diet. What is it they eat at home? Do they have specific foods that are important in their culture? And then you can do a little bit more counseling on how to separate the drugs. Metronidazole and Tinidazole, which are used for bacterial vaginosis, as you know, has a tendency to cause a disulfiram reaction if given with alcohol. So metronidazole has a shorter half-life, so you can actually, you have to avoid the alcohol for 24 hours after completion of the flagyl. But for tinidazole, you actually have to wait 3 days. Disulfiram reaction is sort of a funny thing, because you can get an entire range of symptoms from just nausea and vomiting as the very sort of basic reactions that we all think about, to some people can get flushing, tachycardia, hypotensive, etc. And the symptoms are not predictable, and they're not predictable based on drug levels. So meaning that if you took your flagyl in the morning and decided to have a Bloody Mary with your brunch, that doesn't necessarily mean you're going to have a worse reaction than if you waited a couple hours and drank it with your lunch. Don't forget about alcohol-containing medications, cough syrup, NyQuil. They all can have alcohol in them, which is how they work, and they can often also have that disulfiram reaction. Vaginal preparations seem to be okay, although there's been like 1 or 2 case reports of a patient who got a disulfiram reaction from topical flagyl. And moving on to the complicated reactions, we have the Cytochrome P450 3A4 reactions. And the drugs that we are most concerned about are our macrolides. So what I want you to take from this slide is the fact that azithromycin does not have any cytochrome P450 3A4 inhibiting activity, which is great because that's we can give it without having to think about dose adjusting. However, if you do give erythromycin, then that's something you have to think about. So what is the cytochrome P450 system? It's a family of microsomal enzymes located in the gut, the liver, the kidney, the lung, and the brain. And they regulate how fast and how much drugs are broken down in the body. So that's basically metabolism. And the rate of drug breakdown is regulated by inducers and inhibitors. So what is a substrate? So a substrate is a drug that is metabolized by one of the or more of the P450 enzymes. The inhibitor is the drug that inhibits the metabolism of the substrate. So if you give an inhibitor with a substrate, the inhibitor will decrease the metabolism of the substrate. And for an inhibitor, the onset is usually fairly quick. It's competitive and reversible, meaning that if you do have an inhibition effect, you can dose adjust for it. And the inhibitors vary by potency. An inducer, however, is any drug that increases the amount of enzyme. It's a slower onset, and unlike inhibition, induction persists for several days after the inducing drug is gone. So here I have a cartoon of drug metabolism. So you have drug entering the liver from the bloodstream. You have liver enzymes that metabolize the drug, and then you have elimination. So in normal metabolism, you have substrates on this side that are metabolized through a cytochrome P450 enzyme and become a non-toxic metabolite that you pee out or you poop out. So in normal metabolisms, I made the left equal to the right. So basically the amount of substrate going in equals the amount of metabolite coming out. When you have an inhibitor, so this can be a cytochrome P450 inhibiting drug, what happens is you inhibit metabolism, so the amount of metabolite coming out goes down. And so the concentration of the drug in the blood goes up. So that can lead to additional toxicities. So you would have to dose down your drug in this case. If you have induction, you actually rev up your liver to make more cytochrome P450 enzyme. This is why the onset takes a little bit longer, because you have to make more enzymes. And what happens then is you can clear drug faster from the bloodstream because you metabolize faster. You've revved up the engine, so your drug concentration on your serum side goes down, and you have more inactive metabolites coming out. And in this case, you would have to dose up your drug in order to compensate. And depending on how potent an inducer is, you sometimes can do that and sometimes you can't. So I'm just leaving in here a couple tables of the different HIV drugs and their cytochrome P450 interactions, and you can see they're massive. So if you have patients who are taking HIV drugs, you will want to do some scanning of their drugs through an interaction database checker. And you can see some drugs are inhibitors and inducers at the same time, some are just substrates, and some can be mixed. So you don't oftentimes know what the effect on the drug's going to be because they will compete against each other. So this is a summary table of our common drug-drug interactions for you to look at and how to manage them. And again, remember that azithromycin is negligible when it comes to CYP-3A4 inhibition. This is a table of free internet sources that you can go to look for drug interactions. So Walgreens has a really nice drug interaction checker where you can actually go on their website and punch in a couple drugs, and it will tell you if there's an interaction, and in some cases how to adjust for it. Hippocrates, as well as the Liverpool HIV Pharmacology Group and the HIV website, they all have really good checkers as well. The HIV Insight also has a lot of information on what the drug concentrations will be and how to dose adjust with a focus on antiretrovirals. And of course you have subscription-based services such as Lexicomp and Micromedics, which cost money but are also very good checkers. So going to our last couple cases, you have a 57-year-old woman with bacterial vaginitis where you prescribe metronidazole, 500 milligrams POBID. 2 days later, she calls you in a panic. She accidentally drank a beer with her lunch 15 minutes ago, and she is worried she is going to get sick. This is actually a true case. One of my friends did this. What should you tell her? A, better have a barf bag handy. B, sit down in case you get hypotensive and pass out. C, don't worry, if you're going to puke, you would have done it by now. Or D, do nothing. Okay, so it looks like we're about split equally between sit down in case you get hypotensive and pass out, don't worry, take it as prescribed, or none of these. And the answer actually is none of these because it's likely that she won't have any problem, but you also don't know yet because she just took the medication and it takes some time for the drug to absorb in the body. So what I would say is probably skip the dose, the evening dose if you're really concerned you're going to puke, and then start it again in the morning. That allows the drug some time to clear out. And it won't be harmful in terms of antibiotic resistance. When my friend did this, I asked her, how do you feel? Do you feel hypotensive? Do you feel flushed? Do you feel nauseated? And of course she felt all of those. And the reason being was because she was so anxious about what she did, she was going to throw up. So do a little bit of reassuring. Tell her that, for one thing, you took the dose. There's nothing at this point that you can do. Relax, and just see what happens. And last question, which of the following drug interactions is not a potential drug interaction? A, rifampin erythromycin, B, flagyl with robitussin, C, azithromycin tipranavir, which is an antiretroviral, D, levofloxacin mylanta, or E, doxycycline in Haagen-Dazs ice cream. So this is the last poll. Okay, and so it looks like most people got it right. Azithromycin tipranavir is the correct answer. So regarding rifampin erythromycin, so if you have a patient who is taking rifampin, you should always have a ding, ding, ding in your head to scan for their medications because rifampin is actually a very potent inducer of cytochrome P450-3A4, and it's actually a very hard drug interaction to manage. So anytime you have a patient tell you they're on rifampin, you have to look a little bit into their history and think a little bit about that, and probably do a scan of all their medications before you start anything. And I have some frequently asked questions here, but before I go into those, maybe I'll see if anybody else has any questions that they would like to ask. No? Okay, so maybe I'll go for the first one first. My patient vomited after her dose of azithromycin. Do I need to repeat the dose? And actually, this is a really interesting question. It's not as easy as you think it is. It sort of depends on how soon after she vomited. So if it's within the first half an hour, you typically do need to repeat the dose. But if it's after half an hour, maybe into the 45-minute range, you probably do not, because by then GI absorption will have occurred. The second question was a question that I got asked from the STD Center a few months ago, and it really made me think. So I gave my patient 1 gram of azithromycin. However, the GC comes back positive 24 hours later. Do I need to repeat the azithromycin in addition to my now dose of ceftriaxone? And what if the patient is allergic? Do I give 2 grams now? And this gets to the question about toxicity, cardiotoxicity, efficacy. I mean, you would never give azithromycin 1 gram on its own, so you would need to give it with ceftriaxone. But I would argue if it's within 24 hours, you probably are fine with just giving ceftriaxone by itself. If the patient is penallergic and you have to give a 2 gram dose of azithromycin, it would make me nervous to give 2 grams after having given a dose of 1 gram the day before. To me, that feels like that's a cardiac event waiting to happen. So in that case, I would probably give an additional 1 gram dose. But then if it's beyond 48 hours, you would have eliminated enough of the drug that I think it would be safe to give a 2 gram dose. Do I have a lot of data to support that? No, but I think that makes sense based on the half-life of the drug. And of course, you would always want to evaluate for any underlying baseline cardiac risk factors that the patient might have. Okay, any other questions?
Hello, Kathy. This is Sharon here. Thank you so much for your presentation. I do have a few questions from our webinar audience I'd like to ask for you. The first question is, can you please clarify when you can give ceftriaxone in a patient with a history of penicillin allergy? This is referring back to one of your tables.
Okay, so if you have a patient who has a regular rash that is not IgE mediated, so they don't have anaphylaxis, they never had difficulty breathing, it is definitely safe to give ceftriaxone. But if the patient had a reaction that had hives, or if the patient did have difficulty breathing or had angioedema, had any type of blood pressure changes, that would be a patient I would not give a cephalosporin to.
Thank you. We have another question. This question relates to the studies that you were talking about, the azithromycin and arrhythmia studies. Was hypertension associated with higher risk of cardiac arrhythmias in those studies with the use of azithromycin?
That's a good question. So isolated hypertension by itself, no, but if the hypertension is indicative of some underlying cardiac risk factors where they have any type of electrical issue, an arrhythmia of some type, then yes. Just having high blood pressure or having hypercholesterolemia on their own, likely no. However, in most of these studies, they did actually remove any person that had a higher risk of cardiac events.
Thank you again, and I think this may be our last question, relating again to penicillin. If someone gets hives after taking penicillin, can they take penicillin again?
So the answer to that is an absolute no, because if you have hives, then it's pretty clear you have a type 1 IgE-mediated reaction. So you can't take any penicillin or any beta-lactam in general. So that means anything in the penicillin class, such as penicillin, amoxicillin, augmentin, dicloxacillin as your oral agents, those are all gone. And also every drug within the cephalosporin class as well. So ceftriaxone, cefixime, cephalexin, those are all would be contraindicated.
Thank you so much, Dr. Yang. I know that there are some more questions that have come in. I believe Dr. Yang has offered to answer these questions, and these will be posted along with the recorded webinar. So that brings us to the end of our webinar. Thank you so much, Dr. Yang. And just a reminder for everyone to please complete the brief post-course evaluation. Here is the link to the survey, and you also should have received a link via an email. As I mentioned, the webinar will be archived on the California Prevention Training website. And that brings us to the end of the webinar. Thank you so much. Thank you for all the work that you do. Goodbye for now.